Well, hello and welcome to the CSF March monthly podcast. We've uploaded 3 papers this month to the CSF website, but today I'm going to highlight 2 of these for your particular attention. Now, the first paper is an analysis of the RA Beacon study. This assessed the influence of patient characteristics and prior biologic DMARD use in response to baricitinib therapy. And the lead author here is Prof Genovese, Professor of Rheumatology over in Stanford University Medical Center in California. So remember that RA Beacon was a 24-week randomized, double-blind, placebo-controlled clinical trial of baricitinib in patients with moderate to severe rheumatoid arthritis. Patients in RA Beacon had inadequate responses to more than or equal to 1 TNF inhibitor and had received conventional DMARD therapy. And they were randomized to receive 2 or 4 milligrams baricitinib or placebo for 24 weeks. Now, this particular analysis has looked at the influence of prior factors on likelihood of response, demographics and clinical characteristics, for example, age, weight and geographical region, and also the number of prior TNF or indeed non-TNF inhibitor biologics received. The key outcomes, well, efficacy was assessed by ACR20 response and or low disease activity measured by CDAI less than or equal to 10. Remember, this was a post-hoc evaluation. And these were measured at baseline, week 12 and week 24. A logistic regression model was used to detect significant interactions between treatment and subgroups. So, what are the key results? Well, first of all, thinking about patient demographic and clinical subgroups, there were no significant interactions noted for baricitinib 2 or 4 milligrams versus placebo at either week 12 or week 24 when we looked at ACR20 response and CDAI for age, weight, seropositivity, or corticosteroid use. However, there were interactions noted when ACR20 response was examined by region. There was a larger treatment effect for Europe. There was a CDAI effect by disease duration with a larger treatment effect observed for patients with more than or equal to 10 years. So what about previous biologic DMARD exposure? Well, there were no significant interactions noted at week 12 or week 24 for ACR20 responses between baricitinib 2 or 4 milligrams versus placebo based on their number of prior biologic DMARDs, TNF inhibitors or non-TNF inhibitors, or even for a specific prior TNF inhibitor. With respect to the CDAI less than or equal to 10 between baricitinib 4 milligrams and placebo based on specific prior TNF inhibitors used or number of prior non-TNF inhibitors, and for CDAI less than or equal to 10 between baricitinib 2 milligrams and placebo across all subgroups. Now, higher response rates were noted for Bari 2 and 4 milligrams compared with placebo when patients were considered with respect to their biologic DMARD prior to randomization. And this was regardless of which TNF inhibitor or non-TNF inhibitor was used most recently before study enrollment. So what are the implications? Well, a beneficial treatment effect of baricitinib 2 or 4 milligrams compared with placebo was observed across subgroups, and this seems to be irrespective of the number or the nature of prior biologic DMARDs used. Generally, there's a consistent treatment effect observed across strata with no terribly obvious qualitative interaction either at week 12 or week 24. These data could potentially increase the clinical treatment options for patients who are TNF inadequate responders. Now, the second paper we've uploaded this month that I wanted to bring to your attention is a post-hoc analysis that's evaluated the effect of continuing or discontinuing methotrexate or glucocorticoids in patients with RA receiving tofacitinib. And the lead author here is Fleischmann from Texas. Now, this post-hoc analysis pooled data from 2 multi-center open-label long-term extension studies, oral sequel, and study A3921041. And it was the first analysis to evaluate the effects of discontinuation or initiation of concomitant treatment of either methotrexate or glucocorticoids. Now, we're all aware these are common background therapeutics. We're also very aware that we do tend to manipulate them in clinical practice. In this particular evaluation, patients were given tofacitinib 5 or 10 milligrams twice daily. Patients receiving methotrexate or glucocorticoids at baseline discontinued this treatment during the 3-year period. That was the essence of the analysis. And patients who did not receive methotrexate or glucocorticoids at baseline initiated this treatment during the three-year period, again, this being part of the essence of the analysis. Now, the endpoints reported here, well, there's a CDAI score. Patients were either classed as in remission with low disease activity or were incomplete responders. For patients who initiated treatment with methotrexate or glucocorticoids during the long-term extension studies, CDAI score and RA disease activity parameters were measured, including, for example, tender and swollen joint count and patient and physician global assessments. Now, assessments were at baseline or the last post-baseline visit prior to initiation of methotrexate or glucocorticoids and at year 3. Now, the key results here, around 70% of patients who discontinued or continued methotrexate were in either CDAI remission or low disease activity after 3 years. Most patients maintained their CDAI responses at 3 months to 3 years, regardless of methotrexate discontinuation. In patients who initiated methotrexate, CDAI remission or low disease activity was achieved in 31% of patients at the last post-baseline visit and in 50% of patients after initiation at year 3. 66%, 72% respectively of patients who discontinued or continued glucocorticoids respectively were in either CDAI remission or low disease activity after 3 years. And again, most patients maintained their CDAI responses at 3 months to 3 years, regardless of glucocorticoid discontinuation. In those patients who initiated steroids, 50%, just over 50% of patients achieved CDAI remission or low disease activity at the last post-baseline visit, and 55% of patients after initiation at year 3. Improvements in RA disease parameters were observed in patients receiving tofacitinib who initiated methotrexate, but really only modest improvements were observed for patients who initiated glucocorticoids. So what are the key implications for practice here? Well, patients achieving CDAI remission or low disease activity with tofacitinib could potentially discontinue methotrexate or glucocorticoids and maintain their treatment response. And patients who have an initial improvement with tofacitinib-based therapy but remain CDAI incomplete responders, that is, they have a CDAI greater than 10, may benefit from the addition of another agent, and we might expect some kind of response to occur. Now, just a quick note that we've added one other paper here. It's an evaluation of the safety of tofacitinib in post-marketing during the first 3 years following the first market authorization. And this work comes from Stan Cohen and his colleagues at the Metroplex Clinical Research Center in Dallas. Now, please don't forget that all of the content I've discussed in this podcast is available to you in more detailed slide format with abstract publication as a summary, and that's available at cytokinesignaling.com. And please subscribe to the podcast channel and let us know what you think. Thanks very much indeed for your attention. I hope this helps you in your clinical practice, and I'll look forward to talking with you again in another podcast.